Hi, this is Aslan from the Becoming a Doctor team. Thank you again for joining us for this Friday tutorial, last tutorial of the week, and then you can enjoy your weekend. So this is Dr. Deya, and she'll be giving a tutorial on clinical cases in pediatrics. We really hope you enjoy it. Off to you, Dr. Deya.
Okay, hi, I'm Deyashini. I'm currently an F2. I work at Kettering General at the moment in respiratory. I don't know what else to say about me. Well, respiratory is quite busy at the moment. That's about it. I've done some taster weeks and stuff in pediatrics. My elective was in it. I don't actually have an F1, F2 job in it, but try to keep up pediatrics through like some of the jobs I've done, taster weeks and so on. And then I did a course on acute illness management in peds earlier this year. So the aim is, I think I spoke to Esan, it's obviously impossible to cover all of pediatrics in like a day, let alone an hour. So I think we're going to do 3 sessions. This is the first session, and I'm going to concentrate on respiratory and neuro. Despite me limiting it to 2 systems, I'm still not going to be able to go through everything. So I'm not going to literally go through all the slides because you get the slides later anyway. So you can read some of the more sort of information-heavy slides. But I'll be relying on you guys to kind of engage and like be a bit more interactive. Otherwise, this is really, really dry. So yeah, that's basically it. Thank you for tuning in on a Friday. Like, I mean, not every day kind of feels like a weekend at the moment, but you guys do have like a lot of lectures and stuff anyway. But okay, we've got a lot to get through, so I am going to get started. Okay. Oh no, there we go. Right. So thank you for becoming a doctor for letting me teach you guys. So like I said, we're going to concentrate on respiratory neuro, but also I want you to be aware that, you know, the basic observations that we look out for in adults are quite different to what we look out for in peds, and also sort of recognizing the sick child. I'm going to mention one of the resources now that I've found generally quite helpful. It's a website called Spotting the Sick Child. It's written by like a combination of pediatricians and emergency physicians, and they've got tons of like videos and sound clips, cases, and they go through like the 7 top kind of presentations to peds A&E basically, such as difficulty in breathing, funny turns, and so on. So if you're ever stuck, that is a really good website to use. Okay. So I'm going to start with respiratory, and before we like go into the info, I'm going to do a case. So our first case, 3-month-old Harry is brought into A&E by his mum Sarah. He looks very unwell, distressed, and has a lot of difficulty in breathing. So you've called for help, you stabilize him with some oxygen, and now you need to take a history from Sarah. So, right, so if I can kind of get people to maybe share, like, what kind of questions, first of all, are we looking for in the history? Like, what are your, like, key ones that will help you elicit more information? Anybody? You can put it in the live comments bit if you like. I literally have no idea how many of you guys are tuned in, but or if you can talk. Oh, yeah, I can go back to the case. That's not a problem. Any ideas? about what we might ask for in the history. Someone's just written what happened. As in, so, yeah, so what happened? Yeah, you would ask. Yep, good. So what was he doing before he started finding it difficult to breathe? So you're kind of looking at the history of presenting complaints. So when he became ill, what was happening? How long has he been finding it difficult to breathe? Any medical history? Yeah. Can you expand a little bit more on medical history? Yeah. When did it start? Good. So in medical history, we've got past medical history, and specific to peds, is there anything else that we might want to ask? No. Okay. Yeah. So do they have a history of asthma? Good. Allergies? Yep. Very good. Right, in the interest of time, I'm just going to move on, but all of them are pretty much good suggestions. Birth history, exactly, so that's very important. So the things that are unique to a PEDS history are going to be exactly, so perinatal history, so any complications in the pregnancy, the birth itself, was there any birth trauma, and also any immediate neonatal complications. As you mentioned, like past medical history, including anything like asthma. Obviously, bear in mind this is a 3-month-old, so it's very unlikely that they will have a diagnosis of asthma. Pediatric respiratory physicians try to avoid giving that label until they're 5 years old. So exactly, someone's just commented that asthma won't occur in 3 months, quite right. So you might get a viral-induced wheeze, so this could be a severe viral-induced wheeze, but we don't know yet. So in terms of examination findings, what kind of things, in an unwell child, what kind of things might come to mind that you would see? Okay, in the interest of time, I'm just gonna carry on. Yeah, someone's just commented. Yeah, tracheal tug, accessory muscle use, very good. So signs of respiratory distress, cyanosis, good. Right, good. So in terms of the history, so Harry's become unwell over the last 2 days. He's not feeding well. He's only had 2 wet nappies in the last sort of almost 24 hours. He's very distressed, cranky. He's not had any ill contacts, and he's up to date with his immunizations. Yeah, and he was born, slightly preterm, but it's not really significant. No significant past medical history. Dad smokes at home. Yep, so we're getting in some good comments. So ABC approach for examination, absolutely. I'm not going to dwell on A2E very much in this topic because, going through A2E in detail is something I'm sure you guys know already anyway. And also, it's like, if we go into it in detail, it can take quite a while. But yeah, always A2E and cough, fever, sputum, diarrhea. Very good. Okay, so in terms of the examination, the salient points are, so they're obviously very febrile, increased recommended, so use of accessory muscle and subcostal recessions. There's no tracheal tug, but there might be. So it's very tachypneic. So 60 is like very high, even if you're 3 months old. That's sort of like scoring quite high on the pediatric early warning score, and very tachycardic. As part of A2E, you would do a ECG, let's just say for argument's sake, it's sinus tachycardia. Right, so in terms of differentials, can anyone give me some differentials? Like if you want to comment, and I'll wait until a few have appeared, and then we'll sort of go through what some of them might be. Any takers for any differentials for this child in respiratory distress? So as someone rightly pointed out, it's not going to be asthma as such, but could still be other stuff. Inhaled foreign body, very good. And what's like the particular sign that we might look out for if we're thinking about inhaled foreign body? There's like one particular sign that always triggers us to think of inhaled foreign body. Okay, in the interest of time, I'm just going to move on. So the child had a bit of a cough, not really that much. It's been quite dry. It's not brought up anything, not cyanotic at present. Not unequal, no. Yeah, so bronchiolitis is a good differential. And why did you ask about unequal expansion? What kind of pathology are we thinking with unequal expansion? I mean, obviously, unless you're sort of going back to inhaled foreign body, in which case, yes, so you could have reduced breath sounds and unequal expansion, depending on if it's gone down that side. I wouldn't say they have wheeze so much, no. Just looks very distressed and is struggling to breathe, high respirate, use of accessory muscles, febrile. Sepsis. Yeah, so with inhaled foreign body, that is correct. They normally go right because the right main bronchus goes straight down. Yep. Right, so we've had, bronchopneumonia. Excellent. Some good differentials coming up. Okay, right, good. We've had some good ideas. So this is by no means an exhaustive list, but I've got bronchiolitis, bacterial pneumonia, bronchopneumonia. So whether it's lobar pneumonia or bronchopneumonia, it doesn't matter as much. But I think we've got most of this. Acute exacerbation of asthma, I mean, it would be up there with this kind of picture, but with the absence of wheezing in this age group, very unlikely. The other ones to consider are viral croup. Pneumonia, good. All right, so in this case, anybody want to have a definitive guess as to which one it is? Okay, the interest of time, I'm just going to move on. So I was going for a bronchiolitis kind of picture. So this is quite typical. It tends to happen more sort of around the autumn, winter time. So this time is a little bit, so bronchopneumonia is a good differential, definitely, because it's second in my list. They're very similar presentations. So it would just depend on, so you would do obviously investigations and things to look for it. So in terms of the management of bronchiolitis, bloods, chest x-ray, the supplemental oxygen, so either you give high flow oxygen through a non-rebreathe mask, some some patients need humidified oxygen. You need to give this patient fluids because they're very unwell, so you need to hydrate. So most of the treatment for bronchiolitis is supportive. So in terms of bronchiolitis versus bacterial pneumonia, it's actually very difficult to tell apart the difference. I would say bronchiolitis is more likely in this age group than bronchopneumonia, unless they have a history of lung disorders. Really, that's kind of the only thing to go with. And on a chest X-ray, you'd expect to see consolidation, whereas in bronchiolitis, you wouldn't necessarily see that. Does that kind of help? Okay. So bronchiolitis is most commonly caused by respiratory syncytial virus. It's just typically a viral infection, which happens mainly in sort of the autumn winter times. There are certain risk factors. So having been born prematurely, underlying immune problems, congenital heart disease. I don't know the full extent of the link, but generally cardiorespiratory being so related with most of these respiratory conditions, you'll see that underlying congenital heart disease is a risk factor. Tobacco smoke. So I did mention in the social history part of Harry's history that the dad does smoke at home. We're not going into the moral question about whether they should smoke, but anyway, so passive. So there are some studies that have shown that passive exposure to cigarette smoke can be a risk factor for bronchiolitis. Okay, so I think So in this age group, so Harry's 3 months old, what is the upper limit of the normal respiratory rate for this age group? So this is obviously I've just used a few SBAs throughout. Sort of the upper limit for the normal respiratory rate. Any takers? Okay, got one answer. Okay. Okay, so it is indeed. Oh no, that is the wrong one. It is B. I don't know what's gone on there. Sorry, it is B40. I'll make sure the slides are corrected before they're sent out. 60 is a sign of, if you remember the traffic light system, it's in the very red zone, basically. Yeah, just ignore that red. It is B. Okay. Right, so case 2. 6-year-old Lily was brought into A&E by her concerned parents. Lily became acutely short of breath after dinner about 15 minutes ago. So it's the same kind of drill. So obviously, presenting complaint, history of it. So when did it start? So we've just said it started just after dinner. And so any takers for any additional examination findings that we might be interested in. So going back again, so this is all respiratory. So you're looking kind of for the similar sorts of presenting complaints, the similar sorts of signs and symptoms. So you'd be asking about wheeze, you'd be asking about signs of respiratory distress, which a lot of you detailed quite well. So to Tan, who's just commented, it is 40 breaths a minute. Apologies for the error in this one. I think there was a problem with the transfer of when I transferred it from my base slides. Anyway, it doesn't matter. So moving on to this. So this is a 6-year-old who's become acutely short of breath after dinner. So if I just tell you, so in terms of the history, so it started soon after dinner, chest and throat feel tight, struggling to breathe. So this is a girl who's had 3 previous admissions for viral-induced wheeze and has eczema and hay fever. Allergies are inhaled from already. Yeah, any lip swelling is a very good thing to ask and also to look for on examination. So the mum had a minor cold 5 days ago. Okay. So she was born at term. She's up to date with vaccinations, normal growth, so no sort of developmental concerns, making good progress at school. No other than mum, no other ill contacts. So on examination, severe difficulty in breathing, loud wheeze, chest and face appear red, throat looks swollen, afebrile, high heart rate. So the blood pressure is not of that much significance in children, as you guys are probably aware. I've put it there, but anyway, high resp rate and low saturations. So any idea for differentials? I think we've kind of touched on them. So just a few differentials given the history. If you want me to go back to any slide, just let me know. Back to history, yeah. I'm just going to grab an extension cord because somehow my laptop is already draining a lot of battery. I'll be back. Just have a think, and yeah. So some good differentials coming in. Keep them coming in. I'll be 2 minutes. Yeah, good. Yeah, good. So don't be distracted by everything in the history, but good thoughts. All right, so I think everyone's kind of, am I able to enlarge the slides? I'm really sorry, I don't think I can. Let me just check. Yeah, unfortunately, I'm not going to be able to, but I'll try and talk through it as much as I can, and you'll get the slides afterwards. And I've got my email address at the end, so if you literally have any questions, feel free to email me, and in between nights and whenever, I will reply to you, I promise. Right, so good thoughts. So going back to differentials, absolutely. So anaphylaxis and anaphylactic shock, acute exacerbation of asthma, foreign body. I think you guys had the right differentials. Why is it anaphylaxis or acute exacerbation of asthma? So I tried to put in the bits about viral induced wheeze and her atopic history, because this is often the kind of person who, because of the atopic history, they probably have allergies to a lot of things. So it could be that they could have tried something new at dinner. So that would be sort of a more in detail allergy history that you would have to take. So I was going for anaphylaxis here. It's not acute exacerbation of asthma because you wouldn't expect such an abrupt onset of history. You would expect at least, like an hour or like 2 hours of it getting worse. They can still look red and flushed, but I think the timing and relation to events tips it in favor of anaphylaxis. And someone did put foreign body. I think that's I put that as the third differential here. So yeah, angioedema, epiglottitis are also good differentials. I've just had some comments in. So angioedema is like the step down from anaphylaxis. Epiglottitis, yes, it definitely it could be that, but here I think the onset with dinner is the main thing despite them being an atopic individual. Epiglottitis obviously still happens, but this is a child who's up to date with immunizations and things, so it's more unlikely. Okay, so in terms of the management, immediately you need to call for help, adrenaline, secure airway. So, and obviously, look, A to E is going to be part of all of your answers. So I'm not going to say A to E at the start of each one, because as you've already sort of identified, A to E is vital for any part of the assessment. So in terms of calling for help, you might also want an anaesthetist who's able to secure the airway if needed. IV hydrocortisone, clofenamine, which is an antihistamine, and an IV fluid challenge, because this person's in shock. Right, so there are different doses of each of the things that you would have to give when different doses of the adrenaline, clofenamine, and hydrocortisone by age. So, I mean, that's just an information slide, so you can look at that at your leisure. But at least the adrenaline doses definitely, I would say, are worth sort of committing to memory. Right, so asthma, like I said earlier, is not formally diagnosed until the age of 5, and often children who end up being diagnosed with asthma do have a history of viral-induced wheeze. Atopy, so we're thinking about the child who also has eczema, hay fever, food allergies, possibly nasal polyps. So I don't know if you guys have heard of Samter's triad of, I think it's asthma, nasal polyps, allergic rhinitis, so hay fever basically. So anyway, so a lot of your A2E management may be focused on B, but always remember, if your A is not secure, if you don't think the airway is patent, securing that is the most important job until you move on to B. I'm sure you guys know that, but I can't highlight that enough. So the reason A2E exists is the reason A2E exists in that order is because it's in order of what will kill you first. So the management of acute asthma is back-to-back NEBs. So you can give IV salbutamol, IV magnesium, IV, and you can give IV theophylline. But basically, once you're sort of getting to magnesium, you want to be contacting critical care, like PICU, and thinking of transferring them, because obviously the emergency department or pediatric assessment unit probably isn't the best place for them to be. And then depending on the severity, so if it's mild or moderate, they might just need a short course of oral steroids, so typically prednisolone, or they might need IV hydrocortisone if they're unable to take orally, or if they're very unwell. Right. So these are some of the things that tear apart are acute, severe, and life-threatening. So what defines both of them is having oxygen saturations of less than 92%. The thing that differentiates are some of the clinical symptoms. So some of them you've already mentioned, things like silent chest cyanosis, hypotension, and in acute severe, the peak flow is predicted peak flow is slightly better than in life-threatening, where it's less than 33% of predicted. Long-term asthma management, I've just put this in there. We don't need to go through it in a lot of detail now, but it's there on the slide so that you can have a look at it in your own time. Viral Croup was one of the differentials that's come up. So just a little bit of information, because this is relatively common, as in it only affects 3% of children per year, but it's a good one to be aware of within the respiratory group. It's characterized by a seal-like barking cough, and there are fancy scoring systems for Croup. I don't think you need to become enamored with that, but you can judge the severity sort of based on signs of distress, like do they have stridor? Because generally, if they have stridor, that's a pretty severe form of Croup. If it's just a seal-like barking cough, that tends to be mild or moderate. So often it's just a single dose of oral dexamethasone. If they're unable to take orally, or if they have very severe disease, you can give nebulized budesonide. I've not put the dose there, but or intramuscular dexamethasone at 0.6 milligrams per kilo. I've just seen a question. How quickly do we give the IV salbutamol after giving back-to-back NEDs? It varies, because if you can't see any improvement from the back-to-back nebs, you I guess you can wait 5 to 10 minutes, but you're probably already thinking of the next step. And actually, it's always good to follow the sort of guidelines. So because in one of the hospitals that I worked at, they didn't actually have IV salbutamol as a step. They went straight to IV magnesium sulfate. So you just always check with your local sort of protocols, because they will be plastered around the A&E department, and just check what the protocol is. IV salbutamol is said, but then the studies are of varying sort of opinions about how effective it actually is. So is your question over how much time you give the IV salbutamol, or how long after the nebs do you give the salbutamol? I've just had a question, what is the cardinal sign of inhaled foreign body? The cardinal sign, I would say, is if it's sudden onset, and then you've got reduced expansion and reduced breath sounds over one hemithorax, that's likely to indicate an inhaled foreign body. I think basically what I was getting at earlier was, if you hear stridor in the right age group, always remember foreign body. Okay, right. Moving back to viral croup. So this is from the NICE CKS, which is another important or useful resource, especially for assessing children in primary care or the non-hospital setting, about who to admit and who not to. So basically, the summary of this is, if they have stridor, it's severe or it indicates severe or impending respiratory failure. So all the sort of severe signs we've already talked about will do that. And obviously, I hope you would be thinking that in the severe categories, you would want to admit them to hospital. Some of the other ones are if they have bronchopulmonary dysplasia, if they have, again, congenital heart disease, or if they have signs of circulatory failure, you want to be hospitalizing them. In the severe cases, there is an argument for nebulized adrenaline, but this would be under specialist advice. And very rarely, so in 1 to 3% of cases, of viral croup, so if it only affects 3% of children, you can imagine it's quite a small number who require intubation. But death from viral croup is very rare. So as long as you identify the severity of the croup and hospitalize appropriately, it tends to have quite a good prognosis. Right, so our next SBA, hopefully this time I've highlighted the right answer. Which one of the following is a sign of life-threatening asthma? Is it peak flow of 50% predicted, normal PCO2 in type 1 respiratory failure, needing IV magnesium sulfate, saturations of less than 92%, and rest rate of 30? Okay, had one answer in. This is, I guess I should say, which one of the following is a sign of, good, got some good answers. Right, in the interest of time, Sid trying to be humorous, I like it, D for Deya. Unfortunately, it is B. So well done to who said B. So exactly, so normal PCO2 in type 1 respiratory failure means that they're starting to tire. That's exactly what I was getting at. So we talked about poor respiratory effort as part of the life-threatening, and a normal PCO2 is usually an indicator, because if you're hyperventilating, you're blowing off more CO2, so you'd expect PCO2 to be low. So not only is a high PCO2 a worrying sign, actually even normal PCO2 would be a worrying sign. You are technically not wrong, Sid, when you're saying that SpO2 of less than 92% is life-threatening, but that is also severe. So probably not the best worded question then, but which one of the following signs is exclusively a life-threatening asthma sign would have probably been a better way to phrase it, but I hope it makes sense as to why it's B. Someone's put A, PEFR 50% of predicted is severe or moderate. So usually the PEFR of less than 33% of predicted is your life-threatening category. Severe is 33 to 50, and 50 to, I think, 75 is moderate. Does it make sense why it's B and not just D? D is not incorrect, but I should have probably put which one of the following is exclusively a sign of life-threatening asthma, and normal PCO2 with type 1 respiratory failure would be. Makes sense. Okay, cool. All right. I think there's another SBA next. Yes. So for a 9-year-old child in anaphylactic shock, how much IM adrenaline would you give them? So the concentration is 1 in 1,000 for everyone, so it's the volume that differs. So how much would you give a 9-year-old? Any takers? To be honest, this is a bit of a memorization game. Okay, we've got a lot of answers, so oh dear. Let me have a look. All right, so it's actually 0.3 mils. So 1 mil is too much for any age, unfortunately. 0.15 is for the under 6 months, as well as the 6 months to 6 years category. 0.3 mils is for the 6 to 12 years category, and 0.5 mils is for the is for the 12 and above and adults category. So I'm just going to quickly go back to that slide. Yeah. So if you've remembered it in micrograms, then fair enough. Well done. But sometimes it's important to know the volume, because when you're in a arrest situation, they need to know how much to administer, and that is the volume. So while the nurses will know that anyway, it's sometimes just handy to have it, and it's usually pre-done. The 3 mils is 300 micrograms, not 300 milligrams. So it's all in micrograms for adrenaline, yeah, not milligrams. 0.3 mils is equivalent to 300 micrograms. So yes, 300 mils would be 300 micrograms, but that would be giving 1,000 times too much. No problem. That's all right. It's I used to also initially think it was milligrams, and until I read carefully that there was a C after the M. And yeah, okay, right. I hope that's covered some of those things. Last respiratory case. So 6-year-old Nina is taken to urgent care by Paul following a short history of coughing. In the last 2 hours, Nina has become more unwell, not playing, being more clingy, and there's a strange noise heard with breathing. So in the interest of time, I'm just going to go on to the history, because it's going to be very sort of similar things. I think it's going to be similar things to the ones we've come across already. So started coughing a day ago. Sister Tara was ill last week with the flu, so sort of a cold-like illness. Cough has a high-pitched sound. This is the dad's description. This isn't your thing. Has started drooling and appears unable to speak over the last few hours. That should have an S at the end. not eating or drinking, and the child's just crying. Born at 40 plus 2 weeks, so a term, normal developmental milestones, progress at school, has not received vaccinations as parents believe that they are an unnecessary evil societal construct that cause harm, has previously had viral-induced wheeze. So on examination, febrile, high respirate, high heart rate, low sat, cannot speak, audible stridor. We've already had some differentials coming in. If you keep the differentials coming in, flesh and face lethargic, clingy, not able to open mouth, keeps trying to lean forward and put arms out. Does anyone know the name of the sign? So they literally sort of lean forward and they try to do this. You can't really see on video, but they put their arms out and then their head forward. Does anyone know what that sign is called? Sorry, it's got an amusing text message. Tripod sign, yes, exactly. So sorry for those of you who obviously there's a delay in seeing it, but someone's just commented correctly. So that sign is the tripod sign. Yes, very good. I mean, you guys don't even need this lecture because you've already called anesthetics in the senior and you're not examining the throat. So I think you guys have all got the differential. So it is indeed acute epiglottitis, but remember, don't ever forget foreign body inhalation with stridor. Other things it could be, especially in an unimmunized child, things like diphtheria, bacterial tonsillitis could be, and croup. Okay, so I mean, you guys have already written. So remember, this is an urgent care, so this isn't necessarily in the hospital. So you obviously need to admit, don't examine the throat because it can increase the swelling if they try to, and they can't open the mouth anyway because it's so painful. And the risk of swelling will lead to further airway obstruction. So you need to kind of call the big dogs here to get the airway, and some even end up needing a tracheostomy. You need to obviously give oxygen. So this is all part of your A2E. I'm not going through A2E religiously every time, but always remember with any examination of an unwell person, A2E. And once the airway is secured, think about taking a throat swab and sending it off to look for bacteria. Okay, so HIB is only accounts for 10% of cases of acute epiglottitis since the vaccination has been introduced. So actually the most common is Streptococcus bacteria. Also herpes simplex virus can cause it. Acute epiglottitis is the ability to very quickly progress to airway obstruction, which is why early sort of escalation and prompt calling of anesthetics. And so would we just start them on 15 liters, same as adults? So as much as they're able to say, so you would give through a non-rebreathe mask as much as able in terms of supplemental oxygen. But then once you've secured the airway, to be fair, I haven't really thought about how much you would then give. It would just be enough to maintain ventilation. But if they're needing intubation, then they'll be hooked up to a ventilator and then they will do settings there. So look out for the 4Ds of acute epiglottitis. I don't know if you guys were aware of this, but so drooling, dysphonia, so hoarse voice or like unable to speak, dysphagia, so difficulty in swallowing, and respiratory distress. So they are the 4Ds, which obviously, if not treated, will probably lead to the 5th D of death. Not being morbid, but so here I would just say high flow O2. I can double check exactly how much. I think if you say high flow oxygen as supplemental oxygen, that should be fine. But here, remember, in acute epiglottitis, you have to secure A first, and then once you've got a definitive airway, which most of them will need. So things like Goodell, so oropharyngeal or nasopharyngeal airways, or laryngeal mask airways, or iGels are all non-definitive airways. So if you end up needing a definitive airway, you then attach them to a ventilator eventually. So and that would kind of be your A2E for acute epiglottitis. Right, so foreign body inhalation we've kind of touched on. So basically, as soon as they start crawling around, they start putting things in their mouth. So you've got to be careful for this kind of thing. So we're going to just look at an algorithm on the next slide. So they will need a chest X-ray, and they might need an abdominal X-ray because So obviously, if it's foreign body sort of ingestion as opposed to inhalation, they'll feel sick or their tummy will hurt more likely. But if you can't see it in the chest X-ray, you have to do an abdominal X-ray to see if it can be seen. And if the simple maneuvers that I'll show in the algorithm on the next slide don't work, you're going to have to obviously consider more definitive management. So you would try, you wouldn't personally, but a senior trained person would try a flexible bronchoscopy. If that fails, a rigid bronchoscopy, and if that fails, a thoracotomy. That's very, very rare. So in terms of the algorithm, you guys are probably aware, so you need to try and encourage them to cough. If they're unable to cough and they're conscious, you can give back blows. The exact method of it is something that you cover in APLS, so I'm not going to really go into that. You basically don't do abdominal thrusts. That is the key difference between adults and children. If they're not conscious, so if they don't have an effective cough and they're not conscious, obviously you need to sort of redo A to E, and you need to, it's basically like cardiac arrest kind of syndrome, but we don't need to go into the detail of that. So just remember, no Heimlichs, as in no abdominal thrusts for the choking child. Okay, that is kind of very quick respiratory. I realize it's already 7:45. A lot of the slides in the neurology are information heavy, so I'm not going to dwell on them for very long. The only other things I wanted to say is for the follow-up of anaphylaxis. So I covered the sort of acute management. Where's it gone? Yeah, I covered the acute management. But in terms of long-term, what you would need to do is you would need to take a detailed history. You'd need to see what was the new allergen. So in this case, let's say they had, I don't know, pesto, which contains pine nuts, and that's what set it off. So you would document that as a new allergy, I would say, to all nuts, and then they would need formal allergy testing in a clinic. And you would also want to, while they're in hospital, maybe do things like mast cell tryptase and specialist blood tests like that. But pediatric allergy is a whole big subspecialty, and they would sort of take over the care of that going forward. Okay. Right, neurology is going to be very quick. Okay, stopped. Oh, I had a clip on Stridor. Didn't work, never mind. Okay, oh, there's another SBA. Which one of the following is the management of viral croup? Any takers? Okay, so in the interest of time, just going to say that it's C, so you would give dexamethasone and oxygen as needed. Yeah, good. All right. So CF, the slides are there, so take your time to have a look through them. I'm just going to move on to neuro. So the first case is a 3-year-old boy who's brought in by his mum, and she says Amin feels hot and has had 2 fits. So I'm sure you guys have taken a seizure history. So you need to, the basic questions that you need to ask is, was it witnessed? So obviously in this case, the mum witnessed it. Has it happened before? If so, how many times? And you need to almost take a history for each seizure to see if they're the same or if they're different. And then much like a collapse history, you need to do before, during, and after. So what were they doing before that might have triggered it? What happened during the seizure? Did they lose consciousness? Did they injure themselves? Were they jerking? And afterwards, if they had lost consciousness, how long did it take for them to come around? Any urinary or fecal incontinence, and so on. So he's been cranky, clingy. So he was sat up in bed when he started jerking. So yeah, so you could do a lactate, absolutely, to check for pseudo seizures. So this first fit basically lasted for 2 minutes with jerking movements. So it sounds almost like tonic-clonic movements, but it's self-terminated, and no incontinence, no tongue biting. Second fit happened about an hour ago, similar to first fit, but lasted for a bit longer. And this time felt sick before the fit, but there was no vomiting. Felt hot to touch. Basically, no real past medical history or nothing else significant from the history. Okay. So on examination, temperature's up, but everything else is normal, not wanting to play and not fitting currently. So in terms of differentials, so febrile convulsions, it could be new onset epilepsy, meningitis, encephalitis, space-occupying lesions, which could be neoplasms or abscesses, breath-holding attacks or reflexic anoxic attacks. So here we've gone for febrile convulsions. So again, A to E, but always remember to check the glucose. I don't know why the medication bit's gone so small, but basically you want to establish intravenous access as quickly as you can and give lorazepam. And if you can repeat lorazepam 5 minutes later if the seizure is continuing, they might need phenytoin or levetiracetam, phenobarbital. Again, each hospital will have their own protocol as to what to do. And basically, if it's not terminating and you're needing to go to phenytoin, I would be quick to escalate to HDU or PICU. And because the child might need rapid sequence induction, so RSI stands for rapid sequence induction with sodium thiopental. So this is just a pictorial format of that. This is taken from, I can't remember which NHS trust, but this is one of their guidelines, basically. Okay, so febrile convulsions are typically in the slightly younger age group, and they're typical with viral infections. So we can class the convulsions as simple or complex, depending on their duration and if they happen repeatedly during the same illness. Always, I'm sure you guys will never forget meningitis, but just remember to think about it. So typically it has a relatively good prognosis. And if they've not had any significant past medical history like this child, the risk of future epilepsy is about 1%. Okay, so epileptic syndromes, this is the bit that's going to be very, very heavy on information. So I've sort of tried to summarize them in tables here so you can take your time to look at them, because I don't want to focus on this because it's kind of just looking at the different sorts. We don't need to necessarily go into it in a lot of detail in this lecture. So which one of the following is the definition of a convulsion? In the interest of time, I'm just going to answer it. I think it's, I don't know how obvious it is, but I think there are some you can definitely rule out. So it is a seizure with motor components. So excessive and hypersynchronous electrical activity describes an epileptic seizure. Syncope is to do generally with a cardiac cause of fainting. Initial looking into the distance followed by repeated jerking of all four limbs is meant to be an absence seizure with secondary generalization. I'm sure you guys are aware of the terms focal and generalized. So focal affects one part. So absent seizure is a type or a special case of focal seizures usually, but often children with absent seizures can also have secondary generalization. Seizure following breath holding attack is a reflexic anoxic attack, which is not really an epileptic syndrome as such. Right, last case is a 9-month-old boy brought into A&E by his parents. He's just extremely unwell and has become really drowsy. So he's been unwell for about 2 days. He's had a fever, which initially started with Calpol given by the GP, but he's had recurrent fevers. Only 4 wet nappies. He's not playing at all and has become increasingly drowsy. Born at term and no sort of significant past medical history so far. So basically all of his obs look quite not very good. It's got pale and mottled skin, cold peripheries, neck stiffness, and spotted rash on back, non-blanching. So I'm sure all of you are thinking of the most important differential here, meningococcal septicemia. I mean, the incidence of this has obviously gone down since vaccines have come into fray. But I remember at Mary's there was an 8-year-old boy who basically had to have his arms amputated because despite being immunized and having no underlying health conditions, he just really unlucky, and we couldn't do enough fast enough. So he actually lost the use of both of his arms and ended up getting one prosthetic limb. So that was will always stay with me. But anyway, so in terms of management, A2E, call for help early, IV antibiotics, fluids, and early escalation to PICU-HDU. Most of these kids will probably end up needing that. So someone's written ceftriaxone time, absolutely. So that's usually almost across every just one of the broad spectrum antibiotics used. The exact antibiotics used will change depending on local resistance patterns. So always check your local antibiotic guidelines, but you can give an example of a broad spectrum antibiotic such as ceftriaxone, which is a 3rd generation cephalosporin. So there are a lot of conflicting terms with meningococcal disease. So meningitis is simply inflammation of the meninges, which is often infected, but non-infective causes can include cancers and also trauma. Meningococcal septicemia, so the definition of septicemia is bacteria that are multiplying in the bloodstream. Bacteremia is bacteria spreading in the bloodstream. Septicemia is bacteria rapidly multiplying in the bloodstream. Meningococcal disease is a vague term that can refer to either or both. So in meningitis, you wouldn't expect the child to be quite as unwell as in meningococcal septicemia. So overall in the UK, so meningococcus, which is Neisseria meningitidis, or pneumococcus, which is Streptococcus pneumoniae, as well as Hib are the most common. But again, remember the profiles of the different organisms vary depending on the age group. And in neonates, especially, other ones to be aware of. So here it's got Strep agallectiae written here, which we know as Group B strep. So GBS and Listeria are very common in neonates, as well as E. coli. So again, so the exact antibiotics given will depend on the age group. So this is a pictorial representation, which you can look at in more time, but that's kind of touched on how in the neonates, so up to 1 month of age, Group B strep and Listeria are much more common, whereas as you go through the ages, pneumococcus and meningococcus become more prevalent. Okay. So which one of the following antibiotics is often added in the treatment of neonatal meningitis and why? So in the interest of, so like we said, so in the neonatal period, we worry about certain organisms. We don't tend to, so it's ampicillin for Listeria cover. So you can give amoxicillin as well for Listeria cover. Again, check with local guidelines. GBS tends to be covered by the ceftriaxone anyway. Cefotaxime is a 2nd generation, which is used in some places, to be fair. But here I was getting at Listeria cover with ampicillin or amoxicillin. So recognizing the sick child, I'm sure you guys have all come across the traffic light system. I've just sort of put it here. So here, for example, in the amber category, you've got children with respiratory rates of above 50, if they're aged 6 to 12 months, or above 40 if they're older than 1 year. Tachycardia. So I really like the traffic light system. It's something that's always good to flick back to when you're revising and when you're trying to look for what are the signs and symptoms of an unwell child. Oh, so this is called the Manchu 2 scoring. So green is scores 0, and then amber and red. So it's kind of traffic light system, but this is what they teach in the acute illness management in pediatrics. So this is literally from that manual. I've just sort of summarized it there. So please browse in your own time. I think we've been through most of these embedded within the things, but I just wanted to sort of highlight. So, I mean, it's similar structure to any history that you take, but within the history presented complaint, always think about feeding, number of wet nappies, and how is it different. So if someone has 6 wet nappies, but that's normal for them, that's not really significant. But if they've had 6 wet nappies and normally they have 12, that's obviously a significant reduction in the number of wet nappies. Okay. So perinatal history includes at what gestational age were they born, so that you can see if they're premature and if they had any complications of prematurity or if they had any neonatal complications, and actually also if the mum had any complications in pregnancy. Immunization history, we did a case on epiglottitis, which obviously brought up the importance of asking the immunization history and developmental history. So you can always ask, it's always good to ask the parents if they've been able to bring in the red book, and if they're old enough, then what is their progress like at school. So so family history, depending on the presenting complaint, and then social history. One of the ones that we've not touched on because it's not been as pertinent to the cases here are concerns regarding abuse. So especially in kind of ones where they've sustained injuries, you always want to be thinking about that. Or if something just doesn't feel right, have a low threshold to consider abuse. Involve your senior if you think there are any safeguarding concerns, because that is quite significant. Okay, right. This is the immunization schedule. Again, this is pure factual knowledge, so I don't need to delve into it. I've just put it there because I think it's quite important to be aware of sort of when certain vaccinations are and why certain infections therefore are more prevalent in younger age groups where they've not yet been immunized against certain infections. So take-home messages. Well, I mean, if this was a face-to-face lecture, I would have been able to go through the key examination history findings a bit more meaningfully. So basically, if parents are worried, you should be worried. Always remember wet nappies and feeding. And if they're obviously old enough to be out of nappies, then just ask about if they've been going to the toilet. Signs of a sick child, think about the traffic light system, have a look through it in your own time. And you guys already said, things like cyanosis, accessory muscle use, tracheal tug, recession. So you've got a very good idea of respiratory distress in terms of signs of the sick child. Always think of other things as well, like mottled, dry skin, reduced skin turgor, and things like that. Always, always, always involve a senior. Paediatrics is one of the most senior-led specialties, alongside obs and gynae, and safety net on discharge. So if they've got, say, mild or moderate croup, and you can probably discharge them, you probably want to just make sure they're doing okay. So you can probably call them back into PAU in 2 days' time and assess them. Immunization history, developmental history, they're all important, and consider abuse when noticing like a rash or inconsistent injuries. So I'm sure a lot of you have a lot of questions. I've sort of gone through a lot of that at breakneck speed, but bear in mind a lot of the slides were info heavy, which you don't need me to go through. You can just look at them in your own time. So I think there's that, but thank you so much for listening on a Friday evening. You guys are very committed. So I think it's over to Assam to deal with the feedback side of things.
Hi, yes. So again, thank you, Deya, for that really interactive talk, just going through all the key cases in PEDS. I'm pretty sure everyone here appreciates it. And yeah, so we will see you guys next week. For Dr. Deya, please fill out the feedback and have a good weekend, everyone.
Yeah, have a good weekend. Bye.